Okay, so because of the flip-flop in class today, I'm just going to record the highlights of lecture today for you guys to have so you can rewatch it if you want to. So this was the patient case scenario that we did in class. I'm just going to go through it again so that you guys can hear the dialogue and look through it if you want to before the exam. So a patient has arrived in the emergency department. They have been in a farm equipment accident. The patient has lost a leg and an above knee amputation. They have several rib fractures and were a prolonged extrication. That just means it took a while to get them out from underneath the equipment. Due to the blood loss, the patient is going to be rushed to OR after being stabilized on a ventilator. X-ray shows right lung collapse with ribs 2 through 4 on the right side being fractured. The patient also has a pulmonary hemorrhage and has bloody secretions coming out of the endotracheal tube. It is making her PIP very high on the ventilator, and you're having a difficult time ventilating the patient effectively. So one of the things here that I did is I highlighted in different colors kind of key components of this patient case scenario. I've noticed when I've seen you guys turn in your homework or when you turn in your extra credit for this that some people were highlighting important information, and I think that's really, really smart. When you're taking an exam, if you underline important parts of a patient case scenario, when you're doing homework, if you underline important parts about a patient case scenario, I think that's a really, really super savvy way to kind of differentiate the things that you're going to need to answer questions. The other thing that I always like to do whenever I'm taking an exam or when I was in school is I go through the rest of the patient case scenario and I will put arrows next to numbers to denote whether they're high or low or normal. So for like example, you guys haven't done the blood gas analysis yet, but I would look at this pH and I would put a down arrow next to it because it's low. And I would look at this PaCO2 and I would put an up arrow next to it to remind myself that it's higher than normal. And then I would come to this PaO2 and I'd put a down arrow next to this because it's low. And then for the bicarb, this is within the normal range, so I'd write NL next to it. And I used to do this all the time because it would just help me kind of keep clear in my head the things that I wanted to do. Same with down here, the patient has a hemoglobin of 5, that should be grams per deciliter. I would put low, like an arrow down there, and an SaO2 of 65%. I would put an arrow down there. And again, it's just a way of really trying to sort things in your brain before you even look at any of the questions. Because one of the things that I think happens to most people is you know a lot of information before you take an exam. You know, you study, you make your flashcards, you go through whatever your process is, and then you start taking an exam and your brain just does weird things where you're not sure what I'm asking or the wording trips you up or something like that, and you convince yourself you don't know anything. And so the best advice I could give you, or the best strategy is break it into smaller pieces. So go through your patient case scenario and find the things that you know are true. Identify the values that you know are abnormal. And then when you come to the actual questions, it'll be reassuring to you that you do know this information. You just got to put it together in the right way. And hopefully I'll give you guys enough practice that you feel confident doing that. Okay, so the first question. The patient has 2 major ventilatory issues, airway resistance and compliance. Explain why each one is happening based on the patient case scenario. So I've given you a major hint here by saying that the 2 ventilatory issues that I'm looking for are airway resistance and compliance. So what I really would want in this answer is decreased compliance due to the rib fractures and right-sided lung collapse. Okay, I really want those linked together, and I want it to say decreased compliance. I wouldn't want it to say compliance because of the lung injuries or compliance because of the rib fractures. I really do want it to say decreased compliance due to rib fractures and right-sided lung collapse. The second part, I would really want it to say increased raw because I gave you raw and compliance in the question. So I really want you to specify if it's decreased or increased. So I'd really want increased airway resistance. And I would want you to say due to the bloody secretions taking up space in the airways or the endotracheal tube, because I told you that this patient has excess secretions and that they're taking up airway space. I really want you to list that as the reason that the airway resistance is increased. So just be specific when you're answering questions, especially for this next exam. I'm going to want you to be a little bit clearer about the reasons why, and I'm going to be a little bit more picky about some of these answers. Okay, why is the PIP high? So when you're talking about PIP, or peak inspiratory pressure, your peak inspiratory pressure is that inflating pressure that is trying to overcome your elastic and your frictional forces. So the PIP in this situation is high for two reasons. It's high because you know that you have decreased lung compliance. That's what you put in this question up here. And it's also high because you have increased airway resistance, which is your frictional force, which is up here. So that's why your PEEP is high. A little extra detail that you guys would not get examined to this level is that if you have a high PEEP, a high PIP, but a normal plateau pressure, then generally speaking, you just have an increased airway resistance, usually. If you have a high PIP and a high plateau, usually that's a sign that you have very decreased lung compliance. I didn't give you a plateau pressure in this, so you don't have to worry about that. And really, you aren't going to be looking at that, so you're looking at vents anyway. I just sometimes include these things as like an extra conceptual understanding. The other thing, and I'll point this out when it happens because I feel like, again, going back to test taking strategy, if you look here, I ask you about the two major ventilatory issues of airway resistance and compliance. And then down here, I ask you why the PIP is so high. So I do try to kind of help you uncover your answers with the questions that I'm asking you. So you highlight these two things, and these are the two reasons why your PIP is high. So I do try to help you guys kind of get out of your own way and realize the information that you know and be able to answer it well. Because seeing your homework and, you know, having the email discussions that I have with you guys, your comprehension is there. I just feel like, again, on exams, sometimes your brain just does something goofy. Number 3, how would oxygen diffusion be negatively impacted by this patient based on the lung collapse and the blood in the lungs? So this is really, if I'm talking about oxygen diffusion, I'm talking about Fick's law. I want you to say that it would decrease diffusion of the oxygen, and it's going to decrease it because the collapse of the lung would decrease the surface area that is available for diffusion. And then the blood in the lungs would increase the AC membrane thickness. You could also say that the blood in the lungs would technically decrease the surface area as well. Both explanations for the blood in the lungs would be acceptable. But what I'm really trying to get you to say is Fick's law. This is not a circumstance where I want you to say that they can't get oxygen in or out, or that their lungs are collapsed. I want a very specific reason why the oxygen is not diffusing. And when I'm talking about oxygen diffusion, I'm generally talking about Fick's law. Sorry, I got a little click happy here. Okay, what is the predicted body weight for this patient? 57 kilograms. You just get that from the height. If you're having any issues with that, definitely let me know or get it figured out. I just recopied the patient case scenario so you don't have to keep scrolling back and forth. What would the normal tidal volume range for this patient be? So that's at 6 to 8 mils per kilo. So it ends up being 342 to 456 mils for the normal tidal volume range. The next question that I have is, should the set tidal volume be changed for this patient, and why? So if you look at the set tidal volume for this patient, it's 250 mils. And based on this range, you can see that this is too small for this patient. So I would want you to say that the tidal volume should be increased. The patient is only receiving 250 mils for a tidal volume. That is well below the lower end of the normal range of tidal volume for their height. When you have a patient that's receiving too small a tidal volume, you're going to further collapse their alveoli because you're not going to be properly inflating them. So you're going to contribute to increased lung collapse. You also are not going to have good alveolar ventilation. We talked about how 1/3 of a tidal volume gets wasted in the conducting zone just naturally. So if now you have that 1/3 that's getting wasted to the conducting zone, and you also have a tidal volume that's too small for that patient's height, for that patient's lung size, and you're not properly inflating their lungs, then that means the tidal volume is not making it down to the alveoli where gas exchange would happen. It's not even getting down to that point. So you're going to actually be increasing alveolar shunting. And we know that alveolar shunting is having perfusion but no ventilation. And you're not getting ventilation because the tidal volume is too small to make it to the alveoli. Okay? You need an appropriate tidal volume for the size of the lungs to make sure that you are getting that appropriate alveolar ventilation. And we figure that out by sex, and we also figure that out by height. So just making sure that you have the appropriate tidal volume is very, very important. Solve for the CaO2 for this patient. Is it normal? So the carrying capacity for oxygen in the arteries for this is that 0.003 times 35, and this is your PaO2, which you would get from your blood gas up here. And then you're going to add that to 1.34, which is that constant that you guys have memorized, times 5. I'm getting that number because that's the number of hemoglobin, times 0.65. That's the SaO2 for this. And you end up with 4.5 mils per deciliter, okay? That's low. The normal is 16 to 20 mils per deciliter, so that's low. The next question that I have is, why would it be high or low based on the patient case scenario? And what I really would like you to say very specifically in this, it would be low because the hemoglobin is lower than the normal 15 grams per deciliter. It would also be low because your SaO2 is low at 65%. So I am telling you that you don't have as many buses as you should have. And of the buses that you do have to carry oxygen, they're not full. They're only 65% full. They're not even 100% full. So you have a low amount of buses, and of the buses you have, they're not full. So you would definitely expect the carrying capacity for oxygen to be affected in this way. And we've talked at length about that because this is right here what represents the hemoglobin transport of oxygen. And that's the main way that oxygen is transported. This other part over here, this other component, is the oxygen that's dissolved in your bloodstream. And that's a super small amount. I mean, just ridiculously small. So the way that oxygen is transported primarily around your body is by your hemoglobin, and obviously want those hemoglobin to be full. So you can just, without doing any math or anything else, you can look at this hemoglobin of 5 and the saturation of 65% and just know right out the gate, no matter what, that probably the carrying capacity for the oxygen of this patient is going to be low. No buses, seats are not full. All right, so that is why it's low, very specific in this. And then again, in the same way that I said before, how my questions I try to guide you to what I'm looking for. So I have you solve for the CaO2. Then I ask you to essentially interpret it. Now I'm going to ask you, how would oxygen transport be negatively affected by for this patient based on the scenario? So for oxygen transport, I'm not talking about diffusion per se. I'm talking about how it's transported. So I'm looking for the fact that this patient has low hemoglobin and a low saturation, and that's going to decrease oxygen transport. It's going to decrease that oxygen carry capacity. So less buses, and the buses are not full. So I will try to guide you to the answer that I'm looking for by having you solve for something specific or just highlighting portions of the patient case scenario. Number 10, is the patient hypoventilating or hyperventilating? How do you know? So this patient is hypoventilating. The patient is hypercapnic with a PaCO2 of 56 millimeters of mercury, and we know the normal range is 35 to 45. So this patient is hypoventilating, and it's making them hypercapnic. Then I have you solve for the patient's minute ventilations, which is 250 times 12, which ends up being 3 liters. I just want to point this out down here. You guys probably haven't gotten to the PowerPoint. I think this is PowerPoint 19, where I talk about the elimination of CO2, but I just want to highlight it here because it's going to be a part of your patient case scenarios. The patient is hypercapnic because you have inadequate minute ventilation. You know this because earlier in the patient case scenario, you solved for the normal tidal volume range, and you established really early on that the set tidal volume in the patient case scenario was too small. And we talked about how if you have a too small tidal volume, you are not going to have adequate alveolar ventilation. It's just not going to happen. So your patient has high PaCO2 because of inadequate alveolar ventilation. The way that the body compensates for that, or the way that you as a respiratory therapist can compensate for that, is by increasing either their tidal volume or increasing their respiratory rate or increasing both, depending on the situation. In this particular situation, we would increase the tidal volume because we've already established that it's too low for this patient's size. So when you're talking about CO2, and when you're talking about the removal of CO2, you're going to be talking about tidal volume and respiratory rate. Something to do with the minute ventilation is going to help you remove CO2. So just something that you can definitely memorize now, because it's going to come up over and over again in a lot of different applications. So does this patient have hypoxemia, mild, moderate, or severe? What type of hypoxia does this patient have? Hypoxemic, hemic, circulatory, or histotoxic? So this is going to be in the PowerPoint 17, which the recording is loaded. I really don't know what happened there. I did that several days ago. It's very strange. Doesn't matter. So for when I'm saying, does this patient have hypoxemia, mild, moderate, severe, that's what you're going to do in your blood gas interpretation when we get that far, but that is just those number ranges. So those are the ones that you're going to want to put on a flashcard and memorize. This patient has a PaO2 of 35, which is less than 40, which means they have severe hypoxemia. So that's one classification, severe hypoxemia. Now we need to take the step of trying to figure out what is causing the hypoxemia. So that's where we're going to be looking at the classifications of hypoxia. So that's that hypoxemic, hemic, circulatory, or histotoxic. So let's start with a hypoxemic hypoxia, because I feel like that's the most involved one. So there's 3 questions that you can ask yourself with hypoxemic hypoxia to decide if that's what your patient has. The first question, do they have hypoventilation? This patient case scenario, yes, this patient does have hypoventilation. They have a high PaCO2, so yes. So you could say this patient has hypoxemic hypoxia because of hypoventilation, and then cite the high PaCO2, and that could be your answer. The second component of the hypoxemic hypoxia is a worsening VQ mismatch. So the way that you figure out if this patient has a worsening VQ mismatch is you do... you figure out if it's an increased AA gradient and a decreased AA ratio. So in PowerPoint 17, this is the first slide, we talk about how the AA gradient is your alveolar oxygen minus your arterial oxygen. And this first one, this AA gradient is always going to be a positive number, because your alveolar, the pressure of alveolar oxygen is always going to be higher than the pressure of arterial oxygen. And this happens naturally and normally because we have anatomic dead space and anatomic shunts. So this is going to occur always in people. You're always going to have a difference between your alveolar oxygen and your arterial oxygen. What we're concerned with is how different they are. So everybody has healthy, normal VQ mismatch. What this is looking at abnormal VQ mismatch or worsening VQ mismatch. So a normal AA gradient should be about equal to the FiO2 that you're on. So if you're breathing room air or 21%, your AA gradient should be 21. If you're on 40%, 40. In this case, the patient is on 100%, so their AA gradient should be around 100. And then your decreased AA ratio, you're going to take your arterial oxygen divided by your alveolar oxygen. This is always going to be less than 1, because this arterial oxygen number is always going to be smaller than the alveolar oxygen number. And ideally, you want this ratio to be around 90%. So if this AA gradient is too large, if this AA ratio is too small, it's a sign that you have worsening VQ mismatch outside of what's normally occurring. So the first thing you'd have to do is solve for your P big AO2. So when I solve for that, I end up with 643 millimeters of mercury. So your AA gradient is going to be 643 minus 35. The 35 is coming from that blood gas. That was your O2. And you end up with an AA gradient of 608. That is far greater than 100. So this is telling us that, yes, we have a worsening VQ mismatch. The next thing you can do is that AA ratio. And so if you take that 35 millimeters of mercury, again, that's the PaO2 from the blood gas, you divide it by your alveolar oxygen of 643, and you end up with 5%, which is much, much less than 90%. So both the AA gradient and the AA ratio are saying you have a worsening VQ mismatch. So you could say hypoxemic hypoxia because of a worsening VQ mismatch, and then do these 2 calculations as support for saying hypoxemic hypoxia with worsening VQ mismatch. The third thing that you can do is figure out if you have a shunt, and there's 3 calculations associated with that. So With a shunt, you have the 50-50 rule, which is the patient on 50% or more FiO2 with a PaO2 that's less than 50? And this patient surely is. They're on 100% FiO2 and their PaO2 is only 35. So this is going to indicate that yes, this patient has a shunt. The PF ratio is just taking the pressure of arterial oxygen and dividing it by the FiO2 in decimal form. So you take 35 divided by 1, which is 35. If that number is less than 200, that indicates a shunt. And 35 is less than 200, so that also indicates that this patient has a shunt. If you take your AA gradient, which we solved for up here, and we got 608, and you divide it by 20, and that number is higher than 5, that also indicates a shunt. And if you take 608 divided by 20, you end up with 30. That is much higher than 5. That indicates a shunt. So you could say hypoxemic hypoxia due to shunting, and then you would want to do these calculations to justify that. The next thing I want to point out is you can have more than one hypoxia for the same patient. So this patient has hypoxemic hypoxia. This patient also has hypoxemic hypoxia with hypoventilation, worsening VQ mismatch, and shunt. This patient happens to have all three. Now you can have hypoxemic hypoxia and only have hypoventilation, or you could have hypoxemic hypoxia and have a worsening VQ mismatch only. Or you could have hypoxemic hypoxia and have a shunt. You would probably have that worsening VQ mismatch as well if you had a shunt, but you wouldn't necessarily have to have the hypoventilation. So really understanding these three individual components is important. This patient also has hypoxemic hypoxia and hemic hypoxia. So making sure that if you're going to put one or the other, that you have the correct reasons why. So this patient has hemic hypoxia because they have low hemoglobin and because their SaO2 is low. You wouldn't want to say this patient has hypoxemic hypoxia because of low hemoglobin. That's not the right definition for that particular hypoxia. Or you wouldn't want to say that this patient has hemic hypoxia because they have a low PaO2 and a high PaCO2. That is the definition for up here for the hypoventilation. So making sure you have your definitions tight for when you're picking a particular hypoxia on exam is the only way that you'll get full credit. So really memorize the different hypoxias and what causes them. And that is it for the patient case scenario. So I will get this posted for you guys right away, and then I'll do some other recordings for the lecture today to kind of make up for the fact that I shanked it. So this is the first one.